Dr. Bender gave his talk on ICAD or something along those lines, and he did a really good job of summating it into really very clean, nice categories. And so while TOS can be a very messy disease, and I think that's why Dr. Bates asked me to talk about it, because it can be unclear, and we throw out the term TOS a lot, but don't really know for sure if that's what they have. The nice clean categories that people use for TOS are arterial TOS, which is the most rare form, venous TOS, which is common, but the most common by far is neurogenic TOS. And it's the neurogenic TOS that gets this sort of fake news part of it, but they're different diseases and they present differently. So arterial TOS, the most rare form, presents with arterial ischemia symptoms. So you'll have port cap refill, pallor of the arm, sometimes distal emboli in the fingertips. So they're ischemic symptoms. Oftentimes there's thrombosis or emboli as part of the presenting picture. Venous TOS, you're going to get venous compressive symptoms. So you're going to get swelling of the extremity, sometimes a blue discoloration. These can present with intermittent occlusion, or you can prevent with thrombus formation. And these are both treated by vascular surgery. They're relevant because they involve pain syndromes that we may see, but they're not really treated by our department. I'll talk about it, but not necessarily the technique to fix these diseases. Neurogenic TOS is the one that we think about as nerve and nervous system doctors. And this is kind of the classic form that's been described over time as hand wasting disease, or this is the Gilead-Sumner hand, where basically you have severe atrophy of lower trunk innervated nerves, which mostly are the hand. So these are the categories: arterial, venous, and neurogenic. Each one of these should have an objective finding for you to say that's what they have. In arterial, they'll have subclavian artery stenosis or occlusion. In venous, they'll have subclavian venous occlusion or stenosis. In neurogenic TOS, they'll have EMG findings that indicate a lower trunk, likely pathology. For patients with normal EMG and normal vascular studies, they do not have TOS. And that's where I draw the line. That's where people get confused. They say, oh, they have TOS because I have pain reading in my arm, and their MRI is normal and their EMG is normal, must be TOS. I don't think that exists. I think we just label them that way and it confuses everyone. So I try to just keep three clean categories. This fake TOS I don't think is real, but it's debatable. There are people that think that there is a TOS-like syndrome that exists with normal testing studies. So we'll talk a little bit more about that. In terms of how often is TOS researched? I like putting this up in my slides. You see that there's only been 3,000 studies on thoracic outlet syndrome, which compared to AI in neurosurgery, AI in neurosurgery has more than that alone. In surgery altogether is more than like the 50,000 range. And per year, we're kicking out like 150 papers roughly. There is a little bit of more increase of recent, but for the most part, there isn't a ton of research on TOS. It's been called a lot of things over time, so that may be part of the PubMed thing, as I just gave one term, but it's been called this scalenus anticus syndrome, the cervical rib syndrome, first rib syndrome, Addison syndrome, hyperabduction syndrome. These are all synonymous terms for thoracic outlet syndrome. I use this book for a lot of the figures. It's a really good book on brachial plexus, just all comers. I do have a digital copy if people want to peruse through it. But I just wanted to share where some of these figures are coming from. Dr. Bates likes hearing me talk about nerves because he says it makes it smarter, but really what he feels when he sees this is that he wants to throw up because it's complicated and it makes you feel like it's so mixed up. How can I ever figure out what's wrong with the brachial plexus? So I like to start these talks just by explaining my approach to how to figure out where something went wrong in the brachial plexus. And it looks confusing, but it's actually logically oriented. And I've mentioned this before, but just to reiterate kind of sort of the logical approach to the brachial plexus is it's all based on the roots. And as neurosurgeons and spine doctors, we know the roots pretty well. We know C5 and 6 do shoulder. We know C8 and T1 do hand. And it literally stays that way throughout the brachial plexus. So C5 and 6 are the most superior and end up lateral because that's how you get laterals. You start first. It's like if you're in a race, you're going to be on the outside of where you start. So 5 and 6 start lateral. and they form the upper trunk, which is the most superior and lateral portion of the brachial plexus. And for the most part, they run into the lateral cord, again, staying high and lateral. When you expose in the pec minor region, it's the most superficial branch because it's the most superior branch, set of roots in the neck. And then it stays as the musculocutaneous nerve and the median nerve. Again, both things that are in the front of your body or lateral part of your body. If you take the converse of that, the C8T1 roots, which we know already do hand because we know the spine, they stay medial and inferior. So it's the inferior or lower trunk, and then the medial cord, and then your ulnar nerve, which is medial. So without knowing all the mixing and matching, you should be able to say, if I have pain and numbness in my finger, my pinky finger, it's likely to be C8T1, lower trunk, medial cord, ulnar nerve in that path, because that's what stays inferior and medial throughout the whole course of these sets of nerves. Yes, there is some mixing and matching, and that's where like some can get confused, but it tends to make sense. For example, you know that the thumb is C6. Well, how would C6 get to the hand? The hand is mostly the lower trunk because it's the furthest away from where this is. So it's got to get on a highway that goes down to the hand. So that's where you get this cross of the M, the brachial plexus, because your hand sensory comes from higher up in the thumb, and then it's got to cross to the median nerve. And that's here where the lateral contribution to the median nerve comes. And then the medial contribution is the motor, that's from C8T1. So in a mixed part of your body, like your thumb, the motor is controlled by the lower trunk and the sensory is controlled by the upper trunk. That's how they get together, is through these crossings. So there are some more important crossings than others, but in general, the layout, I think, is logical. So just keep that in mind if you're trying to answer test questions or trying to figure out where something went wrong. So in this example, this is the Gillard Sumner hand. In this example, how did we get this weakness? So why does the hand look like this? What's wrong with the hand? What's that?
And a median nerve.
The median nerve is involved. What part of this? Not the whole median nerve. So it's a lower trunk pathology that we're talking about in thoracic outlet syndrome. So of the median nerve, what does the patient lose? They lose the motor part.
Motor part.
Right,
Yeah.
but median sensory is typically preserved in TOS because that's coming from the upper trunk. But how about ulnar? What about ulnar? Is that affected in TOS? Yes, because it's lower trunk. So ulnar, both sensory and motor, are mostly lower trunk because they start low and they stay medial. So what you're seeing here is atrophy of both sides of the hand. You have abductor pollicis brevis atrophy and you have intrinsic and hypothenar atrophy. So this is kind of the hand wasting disease. And this picture doesn't do as much justice as the first one that I showed, but it's basically a very weak and in late stages essentially useless hand with preserved median sensory. So here's a case that we did Wednesday, Raquel and I, 56-year-old female, 78 years of muscle cramping in her right hand, 2 years of numbness over the ulnar aspect of her hand. She got numbness in the anterior forearm and dorsal hand, and about 2 years of extending her fingers in the right hand. She denies neck pain or radiculopathy. So in this case, you know, the patient's telling you, my hand is cramping, I have numbness in my pinky, my forearm feels weird, and now my wrist extension is getting weak. So to put all those things together, you know, we're not in a single peripheral nerve. We're not talking about median neuropathy and carpal tunnel. We're not talking about ulnar neuropathy. There's too much going on for that. So we're climbing up proximal. Well, it could be the spinal cord. It could be the brachial plexus. So more information is needed, but you're very concerned that there's a proximal neurologic process going on because of how much of the arm is affected. It's hard to get median, ulnar, and radial, because that's what she's complaining of, all in the periphery. That would be 3 separate diagnoses as opposed to 1 in the spine or maybe the plexus. So when she's telling you all these things, you're already thinking it's going to be a more proximal disease that's happening. Well, let's examine her and see what we find. So here's the brachial plexus exam that we try to fill out for our patients in clinic. And this was a modification that I took from Dr. Spinner. But basically what she had was fairly normal proximal muscles until we got to the distal median nerve, which was fairly weak. Abductor pollicis brevis was only a 2. She couldn't quite get her hand fully up. She didn't have full range of motion, even with gravity removed. Her proximal radial was okay, but getting into the fine muscles of the hand again, like EIP, she couldn't lift her index finger off the table very well. And then same thing with ulnar. Her ulnar was weak, especially with things like lumbricals. And on her exam, she had loss of temperature sensation in the forearm, and then a Tinel's in the suprascapular region. So I'm kind of giving you the diagnosis as we talk here. You know what this talk is about already. But here's our cervical spine, and I realize this is only one slice, and you can't see much, but she does have C5-6 and C6-7 degenerative changes. The foramina do have some mild to moderate stenosis. In many places, this patient would just get a 2-level ACDF and say, you'll be fine. This will fix all your problems because you have weakness and numbness and degenerative disease in your neck. But the reality is her spine isn't contributing to this at all. This, in fact, her neck is completely fine. She doesn't complain of radiating symptoms. She has no neck pain. But the reality is we're all kind of primed to look at the spine first. And if we see structural issues, people tend to dive right in with surgery. So just warn you that just because there's degenerative changes doesn't mean that you have to fix the spine. So with clinical suspicion, so I'm already suspicious this is her brachial plexus because her spine was underwhelming. This is a proximal disease because it's involving so many nerves, and she had a Tinel sign at the supraclavicular region. So I'm thinking this is TOS, and that's what you want to do is you want to make your diagnosis before you order your confirmatory testing. The testing really is meant to just prove your hypothesis. It's like when we had our visiting professor here, Dr. Martinez, talking about where do you put your SEG leads. He's not putting those leads in to make the diagnosis. He's putting them in to confirm the diagnosis. It's a much different way of thinking. If you're just putting them in just to see what you're going to get, you're going to be thrown off in wild goose chases in all sorts of directions. And that's similar with EMG and MRI of the brachial plexus. You just order in everyone, it's going to be confusing, but when you have a targeted question to answer, do they have loss of function at their brachial plexus? It is a much more helpful confirmatory test. So what do we see here? Here's their sensory conduction. And what they tested was median ulnar radial and interbrachial cutaneous nerves. This is a very good, thorough EMG done by Dr. Logigan. And what they found was the median nerve had normal conduction velocities, amplitudes, and latencies. And the ulnar nerve, there was a decrease in the amplitude and latency, or increased latency of the ulnar. The radial looked okay, as did the lateral, but not medial interbrachial cutaneous nerve. So just in sensory, we're already starting to form this diagnosis. Median is okay, ulnar is jacked up, and MAVC is jacked up, right? How do you get that pattern of those three things? Normal median, weird ulnar, weird MAVC is going to be either, well, it could be C8, lower trunk, or medial cord. Any of those three can give you that problem. So we're still not kind of exactly sure, but this might be part of the EMG. So let's go a little bit further. So what about the motor conduction? Well, motor conduction, we're losing our abductus pulsus brevis, we're losing our adductor digiti minimi, but the left side is okay. So we have a unilateral issue, right? If it's spine, oftentimes it can be bilateral. This is unilateral, which helps us say, okay, but we're still in the same boat. But now we know there's median and ulnar motor involvement, right? So it pulls it a little bit further up towards the brachial plexus. And then this is the EMG that shows basically the only muscles involved, and there's active denervation, is first dorsal interosseous and abductor pollicis brevis. I know we don't look at EMGs a lot, so I'll explain what I look for in this. Spontaneous activity is what happens when the needle goes into the muscle. And there's a normal couple of spikes that come out just because you stab it. But then it should be pretty quiet because it's a stable motor unit end plate. And when someone has denervation, active denervation, you put the needle in, the muscle fires like crazy. It comes out like crazy because the way I think about it, it's unstable potential and it's kind of looking for nerve input. So it's kind of like singing, like, where's my nerve? That's how I remember it. So spontaneous activity goes along with active denervation. And then when you look at the motor unit morphology, the duration is how long that unit potential lasts for. That happens in chronicity. So when patients when patients have this neuropathy for a long time, they get recruitment from nearby nerve fibers, and that makes the unit potential last longer in time because it's not a clean single unit, it happens over time. So duration means that it's been chronic, and the amplitude depends on how chronic it's been. At first, the amplitude will drop when you lose a nerve, and then the amplitude will climb back up as you recruit nearby nerves. So that's how we use this. Spontaneous activity tells you if it's acute. Motor unit morphology tells you it's chronic and how bad. So their interpretation here is clinically, these findings suggest thoracic outlet syndrome, but it's a really long way to get there. These patients can be challenging because they have so many scattered findings. He has to say this whole long paragraph and probably to us. So here's her MRI, and MRIs in brachial plexus region are notoriously difficult to read. And the reason is because of two things. One, we're not used to doing it. But two is there's a lot of motion in that region, so oftentimes they're poor resolution. The motion comes from arterial venous pulsations and breathing. And over time, we've gotten better and better at subtracting these artifact signals, but they're still present in a lot of these scans, and so the technique matters. UMI does a decent job. Orgonite also does a pretty good job. So I'll try to sort of stop and start and tell you the highlights of what we're seeing here. But starting from medial to lateral, the first thing I look at is the root. So here you have your spinal cord and your cervical vertebrae, and obviously we've already looked for cervical stenosis on the prior MRI. And then you have your roots. So you have all your roots coming out of the foramen, and that's where I start. So the sagittal MRI is the best place to look at the brachial plexus because it's the cross-sectional portion of the plexus. If you look at the coronal, which is most people's instincts, it's actually hard to get perfectly in plane with all of the nerves. So in general, whenever you're looking at any structure in the nervous system, the perpendicular access to that structure is going to be the most helpful, which is why Mattingly says that we live in an axial world, because that's perpendicular to the brain for the most part.
Can I ask you a question?
Yes.
I'm often frustrated, not that I try to look at the brachial plexus, but I'm often frustrated by my inability to visualize the foramina, and I think it has to do with the slice thickness. When you order these MRIs, do you ask for finer cuts of on the sagittal?
I don't. They may do them. I actually don't know what the slice thickness is, but there is a brachial plexus protocol, so they do different things for that than a cervical MRI. I'd have to look into the slice thickness. I don't know what it is off the top of my head. But they do show foramina better. I would agree with that. I think it's part of their job though to make sure it shows that. So you can count all the foramina all the way up, and when we're talking about lower trunk, we're thinking about the C8 and T1 nerve root. So that's what these two are, C8 and T1, and you can figure that out because you can see where the first rib is. So C and T1, here's the first rib. So T1, C8, but you can do the same calculus for any trunk of the brachial plexus. And so as we follow these out, C8 and T1, and right there is where the nerve is getting pinched. So here's the first rib, this is T1 coming along, here's the C8 nerve. And if you watch it continue on now, it's kind of trapped in there and then it comes out to here. So here's the subclavian artery, and these are the three trunks of the brachial plexus, upper, middle, and lower trunk. So this here is the lower trunk, here's the subclavian artery and subclavian vein. And then they go out into the arm. And the further out you get, the easier it is to see. So the way to figure out a brachial plexus is to start on one end, and then scroll to the other, and then go back. And then you kind of have to go back and forth to really understand the course, because there's a lot of things in there and they all kind of blend together. They're similar colors.
Jonathan, in a normal patient,
Yeah.
if you do what you just did and you go out from the foramen, is there fat around the nerve all the way out? Or do
There
you
is more
still-
space around the nerve. Yeah, you could follow it more consistently without a weird turn or buckle or kink.
So to you, that looked
Yeah, so
grossly
I'll
abnormal.
show it again because there's a couple things in there that give it away. And these, I have to stare at this for a long time. It's not like I can see this in a second and figure it out. So here's the T1 nerve, and then I want you to see what happens to that right before the area of stenosis. So here, look at the caliber of the nerve. And then it becomes larger, and then right there it gets stuck through this little corridor, and then it comes out to the other side and is back to its regular caliber. I show that again because it's a subtle thing that's hard to see, but when you see it, it really clinches the diagnosis, and you know, you can get the patient to the right providers. So here's the nerve. Follow this nerve as its course. It gets large right there. See how large it is? And then it gets trapped right there, and then it comes out on the other side, and it's more normal caliber.
And in a normal patient, instead of being against the bone, there would be fat around.
There's fat around it, and that's why the T1 is the best sequence to look at. You don't wanna look at a fat site, you don't wanna look at other sequences because the fat around the nerve can help you see it. So you wanna see its course. You can use stir and other things to look at the, hyperintensity within these elements, but the T1 fat is the best way to see it. So we did her surgery Wednesday, and I don't know, Raquel, if you have any thoughts, what did you see at the surgery?
Oh, we saw a lot. So she actually had, like all three trunks were compressed. So like we joked and said like she got an MVD during the surgery because the upper trunk had like a band of, I think it was a vessel.
Vein, yeah.
But yeah, the vein that ran across it, and like once we ligated it, you could actually see like it had a waist. It was like cinched in, and then you slowly saw that it started to get back its normal caliber. The middle trunk, I think, had connective tissue over it. And then the lower trunk, we could actually feel the fascia from the middle scalene over it. And then once we ligated it, you were able to just see them relax. That's cool.
So the surgeries are a little bit anticlimactic because once you find everything, basically the surgery is over. The whole surgery is finding everything, you release all the soft tissue. I put these slides up because, to remind people how important the history and physical exam is. Knowing the dermatomes and the myotomes is a useful skill no matter what kind of neurosurgery you do. That textbook that I showed in the beginning had these pictures, and I had a Pinterest one that I was using forever, but this is much better, and so I'm switching to this one now, so I just wanted to show it because I found it in the textbook. But for example, this is useful, and in talking about the sensory, this is what I was saying about if you have median loss, that's a C6 thing. Where if you have median loss and C6 are the overlapping differential for sensory loss of the thumb. And so the median nerve does the thumb, but that's C6, whereas the C8 does the ulnar nerve. So having knowledge of this, is critically important. But this is sensory loss and it's not pain. And that's the point that I want to remind people is pain can be, misinterpreted by the brain. Patients just say, my whole hand hurts. I don't know where it's numb. I don't know where I'm weak. It just hurts. And so sometimes you can't really use this information and you can get thrown off by pain. What this represents is true sensation. So if they're losing sensation in their part of their body, that's where the dermatome map really comes into play. And in the hand, the best way to test sensation is either 2-point discrimination or a monofilament test. So actual objective measure of sensation. You can also look at motor function. This was in that same textbook. It's a really beautiful way to demonstrate what each plexal element does and what muscles go to it. And it's cool because it shows both the names of the branches, but also the roots that supply those branches. And they were intending this to be used actually as like you write their exam on it. So they have these little boxes, you can put their strength number in there. But for example, the C5-6 upper trunk lateral cord, when you look at the branches that come just off of that, we're talking about mostly C5 and 6. So you have, your suprascapular nerve, which is C5 and 6. You have your pectoral nerve, your musculocutaneous nerve going to biceps is mostly C6 and 5. In your, thinking about it the other way around, in your posterior cord, which everything gets a branch from, every trunk gives a posterior cord branch. It's a very mixed nerve. So you have 5, 6, 7, 8 in things like ECRB and ESRL because every single trunk gives a posterior cord branch. The lower trunk really only goes to the medial cord. And so your ulnar nerve and the motor median nerve, these are going to be really just 8 and 1 because they don't have a lot of contribution. So, tables like this are available online. If you're ever trying to figure out a plexus, I encourage you to look at the table. With that boring information, here's a little bit of excitement. I asked AI to show evolution of man over time in a video. So this was created by AI, and I just thought this was absolutely fantastic. I had to show it. So it's going through history, showing both not only clothing changes, but also environmental changes, morphologic changes in the face that basically mankind has gone through over time. And I think it's like absolutely remarkable that a computer can just generate this very rapidly. And of course, there's our robots.
What AI program did you use?
I actually pay for ChatGPT now, so there's I don't know if people know, if you pay for it, it gives you like a whole list of elements. There's one called image and video generator, so these are all open AI based things, but it's $20 a month. I thought I'd never actually pay for it because there's a free version, but it's actually way better, and you can make fun things like this. So talking more about the categories, because I think that's why Dr. Bates asked me here today is because what are these categories? So in this paper, they were in this textbook chapter, they basically said there's two kinds. There's vascular TOS and neurogenic TOS. Neurogenic, as I mentioned earlier, is by far the most common cause. 90% of the patients are in this neurogenic category. The problem with neurogenic is really there's two forms of neurogenic. There's this true or classic, and that's what I'm talking about. EMG changes, weakness in the hand, numbness of the pinky finger. That's true or classic TOS. Then there's this non-specific, disputed, or common neurogenic TOS. That's the kind that Dr. Bates hates and doesn't know what to do with, and I don't either, because except I don't know what to do with them either because they don't really have objective findings. And so they have normal EMGs, normal vascular studies, but they have this weakness or clumsiness of their hand and radiating pain down their arm. And so how common is this? So Dr. Illig used to be a vascular surgeon here. Before that department completely disintegrated, he was the chairman. He went to Walter Reed for a while. Now I think he's in Florida, but he's still publishing. This is a relatively recent study where they looked at their institutional experience of TOS. And what they found was that basically neurogenic to venous is about 80-20, when you look at their presentation. And so he thought it was about a quarter of the patients were actually a vascular etiology, whereas the other 3/4 were neurogenic. The overall incidence of neurogenic is about 3 per 100,000. And these are like real neurogenics, the true or classic. So that's the true incidence of the disease. And they put in here, if you were to compare that, that's more common than cystic fibrosis, but about the same as Parsons Turner syndrome. So it's not very common. 3 per 100,000 is also the number of brachial plexus injuries that happen in our country. So 3 per 100,000 is still yet a pretty rare disease, but not quite as rare as cystic fibrosis. In their numbers, they had 82% of their cases were neurogenic TOS. They had 400 of those, and there were combined diseases. So again, these are based on objective findings. So a patient can have an EMG positive for lower trunk, but also venous, subclavian vein stenosis or arterial stenosis. So it's possible to have combined disease. When they looked at the characteristics of these patients, female gender is much more common than male gender, and that's repeated in many studies. It's about 3/4 of patients are females, and it's not really clear why. Dr. Rodenhouse always says women have loose ligaments and tight morals. This is the opposite of that because we're talking about too tight bands and tight ligaments. So I don't really know why women and people have populated things over time, but it is more common in women. Most of these were their first presentation, but they do have residual recurrent or Heck minor syndrome only. That's another variant of the TOS. The kind of scary thing about this is the bimodal distribution of the presentation. Some patients, come early on in the first year of their presentation, but a lot of patients, a third of them in their practice, came 5 years after diagnosis. And that's been my experience here is a lot of these patients are undiagnosed and losing function, and they don't get to me till 5, 6, 7 years after their initial symptoms initially started. And it's not anyone's fault in general. It's just the awareness of the disease isn't very common. And not many people kind of know what to look for. You mix that also with EMG reports that lead you in the wrong direction or MRI reports that are read as normal. That one with the band I showed you, that was actually read as normal. And they had that MRI for 2 years before I met them. And they didn't know that there was that band there. That was very clearly seen by me because I look at this all the time, but even radiologists don't review that many TOS films, just general musculoskeletal radiologists. I review more than them. So, just like cerebrovascular disease, you're going to pick up things more than the radiologists. But this 30%, is the scary part, because patients lose function with neurogenic TOS. And so that, you know, in any kind of social mission, you know, should be increasing awareness of this disease. You know, and median symptom duration, you know, this is again, patients live with this stuff for a long time before they figure it out.
John, the pain presentation, what is that like when patients do have pain?
Yeah, so I'll show a little bit more about that, but basically it's pain in the lower trunk distribution. So it's things that start in the neck and typically radiate down the inside, kind of closer to the armpit, down into the hand.
Does it increase with shoulder motion or?
Yes,
neck
and so there's provocative maneuvers, and I think that might be my next slide or getting there soon, but basically anything that decreases the volume of the thoracic outlet, which is made by the clavicle, the first rib, and the shoulder blade, those three things together make the outlet that all the neurovascular structures pass through on the way to your arm. Anything that decreases that volume, so external rotation or abduction of the shoulder, can decrease the volume of that space, and those can provoke symptoms. And so patients will also often say, I have difficulty doing overhead work, can't change a light bulb, can't do my hair in the morning because anything overhead makes my hand hurt more. The other thing patients say is fast fatigue, because it's the intrinsic muscles in your hand. Cramping is a common complaint. I can only write, you know, a couple sentences and then I have to take a break because my hand is cramping. None of those in isolation make the diagnosis, but all together as a constellation should make you suspicious. In their data, venous was the next most common. They had 84 of those. The patients present with this Paget-Schroeder syndrome, which is basically acute venous thrombosis of the subclavian vein. And that was a third of their patients presented with acute thrombosis. Another 45% or so presented with a chronic occlusion of some kind, and then this McCleary syndrome, 21%, that's a dynamic stenosis that causes symptoms but no thrombus formation. And then 10, arterial, again, by far the least common form, but some patients presented actually with aneurysm, pseudoaneurysm formation of distal emboli were common, and then again, acute thrombus.
That's subclavian artery, not superior cerebellum.
That's right. Subclavian artery. They found that people were a little off in why they referred their patients. Initial referral, about 82% were for neurogenic, but based on the surgery that was ultimately performed, which in this author's mind was the definitive diagnosis, it was only about 3/4 of the time. So neurogenic TOS that's our favorite in this room. That's the type that I treat. And basically, what I believe being TOS is an EMG positive finding. So what are the causes of that? So the fibrous band, as I showed you, that's one. That's probably, in my experience, the most common thing. Is a more subtle type of compression that's hard to see. The obvious ones are a cervical rib. So every once in a while, these patients will have this cervical rib. And just because they have a cervical rib doesn't mean that they're going to get TOS. About 10% in some studies of the population can have a cervical rib. I don't really believe it's that high, but a cervical rib is a rib coming off of the C7 transverse process. So in this picture here, here's the first, this is T1, and this should be the first rib, but they have this other rib here. And where the problem comes is actually this sort of pseudo joint that they get out here. This joint is abnormal, and when the neck moves, that joint isn't supposed to be there. It kind of becomes bulbous and fibrous and grows over time. And as the C8 nerve, which has to pass through this underneath the cervical rib to get to the brachial plexus, this space becomes stenotic. And it, depending on the amount and size of the rib, it can happen at a younger or older age. Patients can present in adulthood with the cervical rib. The youngest person I've treated has been 12 with a cervical rib, so it can happen really along the spectrum.
That
This is-
articulates with the middle of C2 of the normal first rib?
Yeah, the T1 rib.
It's weird.
Yep, yeah, it forms this kind of pseudo-articulate, and doesn't have to. It can be a shorter rib that has a fibrous band. That's what this is showing. So this is sort of a half rib, and then there's actually just a band of tissue forming the rest of the connection to the first rib, but it usually always does land on the first rib somehow. On this side actually is the other example of things that are seen is this beaking of the C7 transverse process. People have done studies where they've looked at the size of the TP7, and that does correlate with TOS. But the T7 TP can be pretty big, or I should say lateral mass can be pretty big. But this sort of beaking of it is a risk factor for TOS, and the thought is that there's actually a fibrous band that comes off of this that you can't see on X-ray. This is sort of the artist rendition of kind of the lower trunk getting pinched by this TOS thing. Here's another example of a cervical rib. So again, making that articulation on the first rib, and this one is also beaking. I do find in patients with cervical rib, there is some bilateral nature to it, but so far patients in my experience have been symptomatic on one side or the other. So I tend to leave the other cervical rib alone unless they have symptoms.
Quick question about that. Do the patient present with other congenital anatomic abnormalities?
Not the ones that I've had. I don't think that there's any syndromes that predispose you to rib that, as far as I know. So this.
Describe your rib resection, in your case on Wednesday, did you resect
So,
the rib?
so that patient didn't have a rib, they just had a band.
Okay.
They have the first rib, so I don't do first rib resection, and I'll go through some of the data why I don't do it. Adam Doyle here does first rib resection. And, you know, it's disputed in the literature, it's like, in spondylolisthesis, do you do a fusion or not? It's unknown, and there's proponents on either side of the coin. And so the first rib resection, the whole point of that is to basically remove the floor of the thoracic outlet to give more space for the whole outlet. That's the theory behind why the first rib removed. With a cervical rib, you do remove that rib, and that's mostly to get access to the space, because as you can see, it's crowded between there, and the rib comes before the C8 nerve. So you kind of have to remove the bone in order to even decompress the nerve properly.
Are there any nuances to that, any
Um,
operative considerations in the rib removal?
Not really. We'll go through some of the operative details more explicitly, but basically it's like exposing any other bone. You find the soft tissue. Once you land on the bone, you use periosteals and Kittners in order to sweep the periosteum and stay on the bone and away from the neural elements. Because the nerve is really plastered, and also the subclavian arteries there, they're really plastered to this rib. It's like the body doesn't like the rib being there, and you get all this reactive tissue around it. And so you land on the bone and you stay on the bone, and that's how you free it. And then once you remove the bone, you have a lot more working space and you can continue your decompression. So that's basically the principle and that's a lot with finger palpation. You feel the hard bone there and then you land on it. Just like you're sweeping the prevertebral space during an ACDF with a Kittner, you kind of get on the bone and strip it free. So this is the give me neurogenic TOS, is a cervical rib. If they have a cervical rib, you're like, yes, I've made your diagnosis. That's the give me TOS for neurogenic. The fibrous band stuff is more subtle and that can be hard. What we were talking about is what makes the thoracic outlet, again, the clavicle, the first rib, and then you can't see the shoulder blade in here, but as you get out further towards the arm, you have your shoulder blade. But I don't think a lot of people sort of realize how close the clavicle is to the first rib. And this is sort of where a lot of the problem is made, which is why people have adopted this first rib resection as the treatment. If you just remove this first rib down here, you can see how everything would be larger. And so in this study, this is venous TOS. So this top left is the patient's presentation. What you're seeing here on a venous injection from distal to proximal is basically the contrast doesn't go anywhere. It just gets spat back right at the catheter, because this is distal access to proximal. And there's tons of collaterals that have formed. There's collaterals everywhere. So these brave souls ventured through the clot and into the SVC, and then were able to establish flow again. And then they abducted the arm. So here you can see the shoulder is down, and then here you can see the shoulder is up. And you can see when the shoulder is abducted, they get stenosis in the vein. So they treated the problem, but then they also proved the cause during the case, which I thought was pretty cool. And this patient got a stent, a subclavian stent, and their problem went away. The other option would have been to take out their first rib, but these authors like to do it endovascular. And here's what's happening. Here's the arm is adducted. Look at the nice big caliber of this of the subclavian vein and the subclavius muscle, and the distance between the clavicle and the first rib. And then here's the subclavian vein with abduction. The shoulder is out, and you get stenosis of the vein, and the subclavius muscle is thought maybe to contribute to that a little bit. But the first rib, in these cases, is removed, which alleviates that compression. So this is venous TOS, and it's pretty cool that you can see on the CTA. LinkedIn has great source of material. Another Matt Benderism. I found this like 3 months ago before I even knew I was giving this talk, but I thought it was so cool that I took a video of it and it just was relevant for today. So here's someone showing bilateral TOS. They're doing bilateral retrograde venous injections. And then they have the patient raise their arms and you can see both sides, they lose flow, left worse than right, and then it's reestablished when the patient puts their arms down. And it's like, well, isn't that normal? Like, you know, your veins shut down when you move your arm, but no, it's not. Your vein should still flow with your arm abducted. Especially to that degree, they're not even really getting, you know, fully out there. So I don't know, I thought that was impressive and, you know, all thanks to LinkedIn. So that's a venous TOS. Again, this is treated by mostly Adam Doyle here, vascular surgery. And the treatments are either stenting or first river section, depending on the presentation. Arterial TOS is much scarier because these patients have ischemia. They are threatened to lose their limb if they have a thrombosis. Venous TOS, they just get swelling. It's a DVT. Arterial TOS, they can lose part of their arm because of ischemia. And so this is a terrifying ultrasound. You have arm adducted, you have great waveform, nice pressures. Arm abducted, silent. There is no waveform. This is the Doppler signal. Quiet, crickets. And so that's a scary finding. You know, and this patient obviously needs intervention. But these are the types of things you see in arterial TOS. Here's bony prominence with subclavian artery kinking. This is basically showing collateral, nothing is going out. Here's your distal emboli, the brachial arteries included. Here's more distal emboli with extensive collateralization. So that's the type of stuff you're seeing in arterial TOS is distal emboli and subclavian artery stenosis. Dr. Pilcher was asking about how do you figure this out? I'm a big fan of provocative maneuvers in the OR, in the office. If I think it's their neck, I move their neck all around and say, did that provoke any symptoms to come? If I think it's their elbow, I have them bend their elbow and I do an elbow flexion test and say, did that cause any problems for you? The things for TOS are all at the shoulder. So you feel their pulse, you move their arm, you feel their pulse again. So just by feeling their pulse and moving their arm all around, sometimes you can get a sense that they're dampening their vasculature with abduction, external rotation. It doesn't always happen, but it can kind of cue you in. The other thing is this elevated arm stress test, your EAST. Is basically you have them hold their arm up and then you have them open and close their hand for 3 minutes. That says, if I did that for 3 minutes, I feel like I'd be tired. But basically patients with TOS can only do it for a few seconds and they're like, oh yeah, my hand is hurting. If it's arterial, their hand is likely to turn white. If it's venous, they're likely to swell.
Is 90 degrees like enough to solicit the response, or does it need to be higher?
I go as far as their arm will go. And basically in a normal person, you can put the arm in any position and you don't lose your pulse. You can try it on your next patient, just try to move their arm around. You should feel the pulse through the whole range of motion of their arm. And oftentimes patients will stop you, they'll this is starting to tingle, you know, and I'm not like torturing them, so I stop doing it. But as soon as it becomes positive, then you stop also. It's not that big of a differential. It's just both sides of the coin. It's either the neck or distal peripheral nerve entrapment syndrome. It's not like it can be that many things, but cervical radiculopathy, median and ulnar entrapment syndrome, a brachial plexus lesion of some kind, so a tumor, which is why I think it's important to image these patients in that region. Don't just assume it's TOS, even if they have a cervical rib, you gotta get some kind of advanced imaging, whether it's a CT or an MRI of the neck to prove that there's no lesion. You can have something like a Pancoast tumor in the lung, a chest x-ray is important, again, because you wanna look for a cervical rib, but also because the mass could be there. And then, of course, things like amyotrophic neuritis, Parsonage-Turner, or something in the spinal cord is always possible. So the workup for these patients is pretty expensive. Every time I see one of these people, I'm like, $1 million workup, because you have to look at their neck, you have to get a C-spine MRI, you have to look at their brachial plexus, gotta get an EMG, and I prefer with ultrasound because knowing the cross-sectional area of the median and ulnar nerve in the arms helps you. And then you have to get an ultrasound of the arteries and veins with dynamic movement of the arm. So you want to reproduce that in the lab. And what they do is they check the waveforms at the wrist and on the arteries and the veins, and they can actually see dampening. So even if I don't feel it when I do that test, they can see dampening, which can cue you into vascular TOS. So this is the basic workup. Of course, your history and physical exam is there, and these are the confirmatory tests. This was a paper out of Zager. Zager actually has quite a few papers on TOS that are mentioned, but he agrees with me. He says there are basically true and vascular. They have this little column here, which is this disputed TOS. And so just to blow it up, it's all about the history and findings. So in the vascular TOS, you have edema, prominence of superficial veins, cyanosis, distal emboli, abnormal AVI, depending on whether it's arterial or venous. In the true neurogenic TOS, you have atrophy of the hands, you have Tinel's, you have provocative maneuvers, which correlate. In the disputed TOS, which I would argue is not TOS, you have chronic pain in the upper extremity, you still have positive provocative maneuvers, and sometimes you can do anything basically and it'll produce the pain, but you have no consistent motor sensory abnormalities and your testing is normal. And so if you look at their algorithm, basically it's the same set of tests in all these patients. The findings are the difference. The findings are you have an artery vein issue, you have an EMG issue or a cervical rib, or it's normal. And then the treatment is really where the key is where Dr. Zager and I agree, is if you have neurogenic TOS, you operate on them, where if you have this disputed TOS, then you do conservative management. So you gotta really resist the urge to operate on a patient with normal testing, even if they say everything right in the office. It's kind of like doing a fusion for back pain and a black disc, right? If they have one black disc, and they have really bad back pain, it's really tempting. I'm just gonna put a cage in there, they're gonna do great. Maybe a lateral to 3-4. Don't do it. Their MRI doesn't suggest they need it. Not gonna get better. It's the same thing with TOS. If their EMG is normal, their vascular studies are normal, even if they're saying the right things, they're not gonna get better. It's a 50-50 shot, basically. So try to avoid operating on the middle column if you can. This is what I was saying about EMG earlier. This came from Zager's paper, but I think it's very helpful. So in terms of median and ulnar, because those are the two major nerves we focus on in the hand, what happens in TOS? So in motor, you really have both of those are affected. They said normal ulnar, but I don't think that's really true. It's reduced and markedly reduced. Really, the abductor pollicis brevis really hates TOS, and you get most atrophy in that muscle. In sensory, this is really the key. The median sensory is normal because that's upper trunk, and then ulnar is reduced. So here's another case, 39-year-old female who had basically obesity and results of that, had about 5 years of pain in 4th and 5th digit, tingling in her fingers that woke her up. When she puts her hands up, it makes the tingling worse. She's dropping objects. She's tried braces. People prescribe wrist braces like vitamins. They weren't even close here, right? Because if anything, it's ulnar, wrist brace for everything, but it's for brachial plexus. So everyone likes to prescribe wrist braces, but that's, I would kind of do some polite education if that happens. Here's her exam, and basically fairly normal, but very weak abductor pollicis brevis. She actually had symptoms on both sides, but the right side was much worse. And then a little bit of ulnar weakness, but not as bad as that other lady. That other lady was much later stage, and she was 7 years versus 5 years. Here's her EMG. So similar to the last patient, we have similar findings here. Antebrachial cutaneous nerve is affected, the medial. The median nerve is normal in terms of sensory. The ulnar nerve is not recordable. In terms of the EMG, she's got first dorsal osseous and abductor pollicis brevis. That's a great combo to see on the EMG for TOS. If you see that combo of ulnar plus median in the hand, it's either C8 or some kind of brachial plexus issue. It's rare to have such bad ulnar neuropathy and such bad median neuropathy that you're going to get both of those at the same time. It's possible, but much less likely. And then they ultrasounded her wrist and elbow. And this is why I think the real patient would perform with ultrasound, because she has changes in both median and ulnar distribution. But this clinches the fact that it's not cubital tunnel or carpal tunnel syndrome, because the cross-sectional area of those peripheral nerves are normal at the wrist and the elbow. So that's how you can use the ultrasound and your EMG together to kind of lead you in the right direction. If you didn't have the ultrasound, you might be wondering, well, could it be bad carpal tunnel and ulnar nerve? But no, it's excluded because you looked at those nerves at the wrist and the elbow. And here's this one was, I think, Orsini. This is PM&R, but it's such a long paragraph. I put this in there because I think they're comical. Like, how many words do you need to say? Taken together, this is likely lower trunk brachial plexopathy, thoracic outlet. Like, he could have just said that, but like, I don't know why these patients incite this barf on the EMG page, but
I want to make sure we wrap up. 5 minutes, so we need to.
Oh, take your time,
We will, what time am I supposed to be done? I think I started late though, so. I don't have a terrible much more. I'll try to get to the data part of this talk. So here's hers, and I'm not gonna belabor it, but it shows a very similar kind of thing. Here's the roots coming out, so here's the T1 root, subclavian artery. Right there, it looks like it gets pinched. And then it comes out, and you can see the three elements, upper, middle, lower trunk. You gotta take my word for it. So what are the technical approaches? And I'll try to be a little bit faster, so I'm taking a while. So you can get to the brachial plexus a lot of ways. You can go there transaxial, and there's two different approaches for that. You can go paraclavicular, you can go above the clavicle, you can go below the clavicle. You can go retro subscapular. You can go transthoracic through the thoracic cavity. So all of these have been described, and there's not really good studies comparing them, but lots of different ways to get there. These are the pros and cons in this study. The supraclavicular approach is my preference, and there is some data to support that being the best approach, but like anything in medicine, you could prove your point just about in any direction. But the benefits are, you can really do a scalenectomy well, which is, I think, a key part of the operation, and you have direct access to the brachial plexus. They thought the downside was a poor cosmetic appearance, but I actually don't think that's true. It heals like an ACDF incision, which is pretty good. In this paper, the transaxillary approach, and this is for all comers TOS, was about 75%. The supraclavicular scalenectomy with first rib was 77%, and the supraclavicular without first rib was 85%. So I like to focus on the first rib part of it because I think that's a big difference for the patient, both in terms of the risk of the operation, but also the pain and recovery and success rate. When you look at the complications of each approach with these two, you have a pleural injury rate of 20% and a death is 0.07%, but still a death in this. And the scalenectomy without first rib resection, somehow they still got in the pleural 5%, which seems high, but no deaths. And I think it's just a safer thing to do to me. This is what the approach looks like on the way in. And so just to orient you, sorry for the gross pictures, but just to orient you, medial is to the right, lateral is to the left, inferior is down, and superior is up. So here's the upper trunk of the brachial plexus. This is the phrenic nerve running along the anterior scalene, and here's the anterior scalene muscle in red. And what they've done is they've divided the scalene muscle. So division of the scalene muscle is both part of the operation because it's hard to find all the plexus elements because it covers part of the plexus, but it's also the treatment because the scalene muscle is where a lot of the fibrous bands and connections arise from. So dividing the scalene muscle, you both find everything, but also free the nerves of their compression. This is the subclavicular approach. I've done this with Doyle, and it gives you really nice access to the vasculature. So if there's a combined arterial, venous, and neurogenic, you go subclavicular with vascular. I've done a couple cases with Doyle. If it's just me, I'm doing a supraclavicular. Triangles of the neck are fun. I'm not going to belabor that because of time, but there are some vascular things on the way in. I told you wrong, Raquel, so I wanted to tell you properly. I named this wrong. This is actually a suprascapular artery or just a branch of the external jugular. I thought maybe it was transverse facial, but that's higher up. It could be, but there's often a crossing vessel of some kind. I was going to show a technique video, but maybe I'll just skip that for time's sake. Here's another paper showing the exposure. So this is your initial exposure. You have your clavicle down low, your neck up high. Here's your phrenic nerve. There's lots of fat in this region, and that can be the hardest part of the case is digging through the fat because you're afraid of hurting something. And the real key to that is just staying in line with the plexus. If you're parallel with the plexus and you're dividing things, you're unlikely to hurt something. It's when you go transverse to the plexus that you're going to cut a nerve. So as long as you stay parallel, there aren't many nerves that go the other way that you can injure. So stay with the nerves. And then again, after your scalenectomy, so that's sort of the before and after, you can see how well you can see the upper, middle, lower trunk, and even the subclavian artery. This is an example of a cervical rib, so upper, middle, and lower trunk. And the lower trunk is kind of draped over this cervical rib. And so as Dr. Pilcher asked, how do you get rid of this? Well, they've already spent a lot of time cleaning this bone and scraping with the periosteal. And you can see how red the root is. This root really didn't like being moved because it's so stuck. It's been there for a while and it's irritated. Here's a story of the outcomes of these. So in comparing supraclavicular first rib resection to transaxillary first rib resection to rib sparing supraclavicular approach. This is the one I do. This is the one that Doyle does. And so, looking at the proportion of women, again, in the 75% range for women. And in terms of the outcomes, this is what people got. So for the rib sparing supraclavicular approach, 97% of people got better. And this is using PRO. For the transaxillary first rib resection, it's still pretty good. It's approaching 90, but not quite as good as the rib sparing. And this was a meta-analysis, and so it's hard to know, is this surgical technique? It's not prospective or randomized, and so you gotta take it with a grain of salt. This is the PRO that a lot of people use for a TOS. It's called the DASH score, and that stands for disabilities of the arm, shoulder, and hand. And it's like Oswetry disability index for us. This is what ortho basically uses for TOS. And it's a 30-point score, but it's basically like PRO type questions, like can you open a jar, can you turn a key, all these things you kind of expect for upper extremity. And so here's the DASH score for the different techniques. So the first column is 1.1 is the supraclavicular first rib resection, then the transaxillary first rib resection, then the rib sparing. And you can see the trend that's happening. So rib sparing is commonly studied, but had the best outcomes. This is the improvement in the DASH score. So they had a much better, proven in a meta-analysis for much better outcome functionally. In terms of complications, they also had a much lower complication rate. And so if you look at this overall complication rate, again, first rib resection through above the clavicle, first rib resection below the clavicle, and then rib sparing, it was 3.6 versus 15, which is a huge difference. And the complications really are pneumothorax, right? We're less likely to get into the lung when we're coming from the top and not messing with the rib than when we are. So when I look at that, when you get better functional outcomes and a lower complication rate, I don't know why you'd ever take out someone's first rib. I have done it, and Doyle thinks it's a very important thing for the subclavian artery, which might be a different calculation than I'm doing. But I don't see any reason really to ever take out the first rib. The only time that I've thought about it is in recurrent syndromes where the scalene's already been dissected. There's not really another thing for me to do there. Here's another meta-analysis. Every time I make one of these talks, I learn something about how large combined studies should be done. This is the minor score. This is a way to actually measure how well the meta-analysis collected the data. And basically, they look at the quality of publications. And so if you're ever doing a meta-analysis for non-randomized trials, the minor score is something you should include in the publication. And they also found a huge difference in the DASH score. Somebody in here, Dr. Bates, I promise. So what do you have with that patient that we don't like with normal testing and normal vascular studies? I send them for a scalene Botox injection because my theory, and there's some literature to support this, but it's not very good. My theory is that if I paralyze the scalene and they get better, that's a pretty good indicator that if I cut this scalene, that they'll get better. So I really don't have anything else to offer them. They have normal EMG, they have a normal MRI, they have normal vascular studies. I don't know what they have normal cervical MRI. I don't know what to tell you to do other than try this. And it actually turns out that it does work in about a third of patients. So these patients after this Botox, 70% of patients got relief. But in the paper, a third of them went away. Their symptoms completely got better. And I kind of been likening it to like the epidural steroid of the spine. When I send a patient for an epidural steroid for a lumbar disc or something, I lose about a third of them. Their symptoms just go away and they get better for SI joints as well. If they had Botox success and the surgery, they were up in the 90%. So basically what this paper is saying is that Botox can be used to predict success of thoracic outlet surgery, and the combined approach of using Botox plus surgery is fairly effective for improving the patient. But honestly, I couldn't find enough studies, and that's an area of research for using Botox in this category with normal testing. I think that's a area to study. early versus late, and I think this is one of my last slides here. This is the important thing, the important message is, and I mentioned this in the beginning, the delay of diagnosis is hurting patients. And this is what this study showed. It's a very small sample. It's only 35 patients, but they looked at great patients who were treated late versus early, and there was a big difference in the amount of improvement. This is their preoperative score, and you can see in the early group, their DASH score is lower, which is better. So there's already a functional difference between these groups at the time of presentation. But things like, the amount of muscle wasting and pain, is gonna be more in the late group. And basically what they found was, in the late group, their DASH score didn't improve as much. So they went from 34 to 23 versus 27 to 10. So it's hard to get them back to normal. And this is similar to what Dr. Manava was saying when he presented the PRO work, is that if you wait too long to treat someone, they actually don't do as well. And so we have this tendency to not offer surgery for certain patients. We've got to try conservative management. Have you tried PT? Have you tried injections? But in this disease, in true neurogenic TOS, you are hurting them by not doing surgery earlier. It's kind of like someone with a big disc herniation and weakness. Just sitting on that is not a good idea. So these patients with a weak hand and suspicions for TOS need urgent care, not years of delayed conservative therapy. I'll finish with this thought, and this is where the field is trying to go. This is the transthoracic view of the thoracic outlet. And I just think this is so beautiful. What you can see without even cutting anything to start with. All you've done is put a camera into the thoracic cavity. And what you have here is you have your first rib.
Well, presumably also.
You're using a dual lumen tube in your oral ventilating one. That's correct. So atelectasis is a risk of this, but it's a really beautiful view. You can see the subclavian vasculature, you can see the first rib, you can see your T1 nerve root. You can see all of the elements of what you need to do. And because of that, people have said, oh, I can take the first rib out with a robot. I'm trying to get them to do that here because I think the robot is cool. I'm really close with one patient, but haven't done it yet. But I'm convinced in the next 2 years, I will convince a thoracic surgeon to try this with me. And basically what you do is you find the rib, stick a kerosene down one of their trocar ports, you bite the rib for them, that's the neurosurgeon part of it, and then they take the rib out and the vasculature is decompressed. So that's kind of where the future is going, less invasive, the scar on the neck, the digging through the plexus may hurt the patient. Dropping the rib out through the chest cavity may be an emerging thing that's more people are doing. I'll tell you, there's politics though at this institution. Dr. Doyle, who does the vascular stuff, doesn't want thoracic to be doing these. So that's the collision that I personally ran into and why we haven't done one yet. And that's always an interesting part of medicine is the politics with who treats what disease. But at the end of the day, we're just looking for the best care for the patients, and collaborations are usually better for patient care. The pearls for this talk, and this is my last slide, sorry for going over. TOS is difficult to diagnose due to its rarity and overlapping cervical radiculopathy and peripheral nerve disease. When the diagnosis is supported by EMG or vascular abnormalities, it's very effective. 80 to 90% range of patients get better when you have objective evidence of thoracic outlet syndrome. If the patient presents with weakness in EMG, surgery should not be delayed because it will cause more disability. Patients with mild objective findings can undergo a scaling Botox block to provide relief and hopefully predict scalenectomy. So those are the pearls from the talk. I hope that everyone enjoyed that. And happy to answer any questions. We'll get to our next event.